my pleasure today on Physio+10 to welcome Mark Jones. Mark, I like to get these ones kicked off by asking the participant, the guest, yourself, what it was that sparked you to take in physio. But in asking that question, I remember now you actually didn't start with physio, did you?
No, my first degree was psychology. And then after that, I worked for a while around the field of psychology and then went back and did physio. So it's a long story. I'll make short that even when I studied psychology, I had an interest in physio. And that really stems from my father was a physio, an academic, a head of school. So I grew up with physio. I've got memories as a little kid sticking my hand in the paraffin bath and making hands of paraffin. So I think I actually avoided it initially because I didn't want to necessarily follow in his footsteps. And I liked psychology. But as you probably know, psychology, a bachelor's of science in psychology doesn't make you a psychologist. You need to go on and do a master's degree if you want to pursue that. So what I did is I did psychology. I finished. I worked around the field because I worked in an institution for children with intellectual disabilities as a behaviorist, so to speak. And I worked with a physiotherapist there trying to help him with his clients and the behavior problems. And it kind of brought me back to physio. So I then had to decide whether I pursued further studies in psychology or went back and studied physio. And I applied to both programs and hoping that might help me make the choice. I got into both programs, but I chose physio and I've never looked back. I've really loved my career and think I made the right choice. But of course, psychology is relevant and it's a good background.
Yeah. I mean, I've had a couple of friends that have gone through psychology. And as you say, you can do a degree in psychology and you don't come out as a psychologist. And they sort of cutely describe psychology as rats and stats. And I hadn't realized the lack of human contact, so to speak, that you get from a psychology degree. Where do you fall in your family? Like you said, your dad was a head of physiotherapy and you obviously don't have an Australian accent. So maybe you could explain a bit more about your family then.
Yeah, so American, mostly from the Midwest of America, Iowa, but like a lot of Americans, we moved around. So I lived in Iowa, and then my family all moved to Florida. And my father was the head of school at University of Iowa, and then he was the head of school at the Florida International University. And I finished off high school in Florida. I did my psychology degree at the University of Florida, and then eventually went back up to Iowa to do my physio training, and then moved around with working. So the Australia experience sort of all emerged out of after I had worked for a few years. I had a really fortunate first job. I worked with some amazing clinicians that all postgraduate trained in different approaches, particularly in musculoskeletal manual therapy, including two that had our Australian experience. One was Joe Farrell, who studied out in Perth under Bob Elvey, and Brian Edwards. And another one was Tom Holland. And so I had this exposure to Australian manual therapy and made the move to Australia. And then that's another story why I ended up staying.
So just explain it. So you did your undergraduate in Florida as a physio.
Yeah.
And then having worked for a few years with some physios, specifically with some, Australian trained influences, did you come out to work or did you enter a program like a postgrad here?
No, I came out. So when I had my first physio job, it was in a hospital in South Bend, Indiana. And I really landed on my feet because I went there because of one man, a guy named Tom Holland, who had done a 3-month course for Jeff Maitland in Adelaide, but he was also a PNF instructor. He himself studied under Dorothy Voss, who you might know was one of the originators of PNF alongside Maggie Knott. And then when I got to that first job, it turns out there was Joe Farrell there. There was another guy, Bob Johnson, who did the USB long-term program, another guy, Terry Olson, who was a really skilled PNFer. So I had these amazing clinicians around me, and I had all their PD that I got, as well as I was like a lot of new graduates. I was hungry. I took everything I could in musculoskeletal. So I had Kinsey and Grimsby and Roccabato. And I recognized, because I worked with these other guys, recognized the difference between PD and long-term training programs that they had done. Even though they were in different approaches, they were all amazing in their own way and really expert clinicians. So I decided I wanted to do that. And back then, and we're talking 1985, there really wasn't much on offer in America in terms of long-term programs in manual therapy. So I went ahead and applied to the Adelaide program and got accepted, and said to my family, I'll see you in a year. That's what it was. It was a 1 year. Back then it was a graduate diploma. And I headed off to Adelaide.
And how crazy did they think you were heading off to this backward place called Australia to do some physiotherapy education?
Well, exactly. And, Americans are often made fun of because they don't know much about the rest of the world. And they're literally having to look up Australia. Where is it? And they knew nothing about it. Yeah. I did know. I worked with guys who had spent some time there. Yeah, they thought it was all rather crazy, but I was still very young back then, and you do that stuff.
Yeah, and I remember a similar thing, leaving Australia and then going to Canada and working there for a couple of years, and the same thing, that urge to learn and courses every weekend. And the PD is good, but it wasn't until I did a 3-month program at University of BC in Vancouver that I realized the benefit of having that continuous type process as opposed to a 2-day course or a 3-day course. But yeah, certainly meeting Americans in those travels, Alaska was their overseas holiday. It was quite interesting. Okay, so we got to...
there's nothing on long-term training programs. I'm just a huge advocate of that. I always have students ask me advice on what they can do, and there's more than one way to advance yourself. It's not the only way, and not everybody can do a long-term program. But what they have the advantage of is the supervised clinical. You can learn stuff on PD courses, but what you then find is to go back in the clinic and apply it is really difficult. You need to have that supervision, and you can get that in a good practice. If you get your first job in a good practice that has mentors there for you, it's another great way to learn. But having that, I think, is critical.
Yeah, it's almost like you can read it, which is what the PD course is providing you with, but then applying it, that takes in a whole new gamut of understanding and skill sets, for sure. Now, you landed in Adelaide, and I understand this would have been the last year that Jeff was actually teaching the program. Would that have been correct?
Teaching full time, because he stayed on like as a guest presenter for a number of years, and he'd come in and he'd do some lectures and he'd do some patient demonstrations. But yeah, that was the end. That was the last time he was a full-time running a program and instructor.
Yeah. So what are your memories of that course? Because obviously it was a big decision to come to Australia, and you're still here. So it was a significant year in your development, would you say?
Yeah, huge. And I think probably most people you speak to that did one of these programs, not just the Adelaide, but all of the programs in Australia that I think are excellent. they will say it was sort of a career changer for them in terms of not just giving them advanced knowledge and skills, but kind of setting them down a pathway to be able to do other things, to be able to teach, to win university positions, to research, to publish. So it opens a lot of doors if you're interested in that.
Yeah, yeah. And I understand there was a bit more of a heartstring moment for you there associated with that course as well.
Well, it depends what you're referring to.
I'll leave open question.
Yeah. So I would say that year was an amazing professional year for me because it just took me to a whole new level of thinking and skill, I guess. It was also a year where I became good friends with one of the, and I quickly emphasized that while we didn't get into that year, after we graduated, we eventually dated, and then she was Helen Rubenak back then, which some people might even recognize from some of the neurodynamic early research. She did one of the early studies. And then we married. So Helen Jones, my wife now.
That's awesome. Yeah. The other thing that I was wanting to sort of ask you about with regards to that year, as well as personal and professional development, was just what you remember of Jeff. We've had in the last few podcasts a few people that have had different interactions with Jeff Maitland, and in a way it'd be also great to get your take on what you remember of Jeff in his professional teachings that you were involved with.
Well, I mean, as a very young physio and student, then I was kind of intimidated and a bit in awe of him. But I also have this incredible respect for him. And I would say the other sort of contributors to our profession. I'm a little bit of a buff in terms of the history of particularly musculoskeletal physio. And it just really saddens me when I come across our own undergraduates who don't know, even Jeff Maitland, who's from Adelaide, but then they don't know the other key figures in our profession, like where have these ideas come from? But yeah, so Jeff was incredible. I think his biggest contribution was his methodical assessment, even though you can easily criticize things that didn't include. You got to put it in the context of when he taught and practiced. And what he taught was just an incredible methodical approach that was also not a protocol. So he was so creative in using things from the patient's story. So he had this amazing subjective where he really got to know the person. I mean, he never would have labeled it psychosocial assessment, but it really was in many ways. He really got to know the person as well as their problem. And then his approach was very adaptive. Admittedly, it was very individual and probably joint bias, but it was very adaptive to the patient's functional problems and his emphasis on function. He had different, he used the words that are trendy now, but it was still the same approach, really trying to get the person back to their participation, their function, and treating in very creative ways. I'll never forget one time a patient demonstration where he was doing something on the floor with the patient, and he turned around and looked at this group of students and said, "I've never done this before in my life." And here was a man in his late 60s, basically making something up based on his assessment of that individual. And that really stuck with me because you don't see that as much now. And that's because I think people do what they're taught, and they're often not taught how to reason well, always, but sometimes. So that was very inspiring of him. He was a bit In hindsight, I would say he was a great teacher for the good students, maybe not so good for the weaker students. Like if you didn't ask the one question or do one thing he wanted you to do, he'd be all over it. So some students who weren't as good at communicators or their hands weren't maybe as good really struggled under him. That's maybe a little critique, but he just incredible what he contributed to skeletal physio, I think.
Yeah. And I love the way you brought out his ability to be adaptive in his thinking, because when I was in Canada again, they really didn't have a manual therapy guru, so to speak, when I was there in the early or the late 80s. Yep. And they took Maitland as their subjective objective component, but then they would move on and they would teach like Yander or Carlton Bourne or somebody else in the treatment type components. And you could see they almost had a potpourri of the better types of aspects of manual therapy from around the world, and they had integrated it into a process. And that's where I became, quite familiar with Jeff's work, even though then I came back and did postgrad and obviously got fairly indoctrinated. But I found it interesting coming back to Australia to do my postgrad in MNIPS, that it was so joint focused and they didn't have these other aspects. So it took a while, and I think that's something we need to recognize, that these things were built from nothing and that we've been able to build on top of those. So we've been able to overlay that understanding in that clinical reasoning process with the biopsychosocial model and have been able to interplay these different bits to it. But it doesn't take away the critical importance of what was started for us to get to that point. I think that's something that often seems to get forgotten, that we haven't just created this, someone else created it and we've stepped on top of that and built up on that process. And I think, Jeff was amazingly creative.
I think, that really summarizes it well, because, even today in our own postgrad program, we don't teach everything. You simply can't in the time available. But things that we don't teach can very easily be learned later and integrated, because we teach a way of thinking and a process that enables that. It makes it very easy to add stuff because of this kind of open yet critical way of thinking.
Yeah, it's very adaptable in that way. Hey, I wanted you to share also a story before we move off your experiences in your postgrad year of potentially where the grade 1 mobilization bending knees of the fly concept came from. Can you share that story with us?
Yeah, well, it's essentially how Jeff tried to kind of metaphorically explain how gentle this so-called grade 1 was. So you imagine you're putting your thumbs on the back of a fly and you're doing these mobilizations, but they're so gentle, they're only causing the fly to do little knee bends. And it's quite funny, because in my year, 1985, when I studied, we did little group did a wine bottling tour, and we made our own label, and our label was a fly with 2 thumbs on its back. And I still have a couple of bottles of with that image on it. So yeah, it's one of the things that sometimes people like to pick on, and I find people who haven't studied either with Jeff or they studied by a second or a third generation person, I find it interesting what they conceptualize as Maitland concept. And often grade 1s come up and you say, really? It's not what the Maitland concept was about. And even though, like now, we would still teach, there is a place, very gentle manual therapy as an adjunct in management. We wouldn't be teaching a true grade 1, because you ask the average person, I can tell you what they call a grade 1 is not a grade 1, according to Jeff. But we would teach what Jeff would call a grade 2. And what you find, in my experience, what you find is a lot of people coming back to do further study, they're not very gentle. Their average manual therapy technique is at least a 4. They're always in some resistance. And so the idea of, can you actually be gentler than that? Can you back that off to something even more gentle? Kind of forget the sort of 1 or 2, but just how gentle can you be? And then of course you got to work out, where does that fit into our practice, and not just the efficacy of it, because the efficacy's there. It can be as useful as dry needling as far as modulating pain. It just isn't really the best cost-effective way to treat. So there's a lot more needs to be thought about, and we now emphasize that. But we haven't thrown it out because we think gentle treatment is a thing to learn. And Jeff, I would say, was both the most gentle therapist, and I've seen him demonstrate this live on a course with patients, but also the strongest. He would treat stronger than anybody I'd ever seen treat. And that's also gone now. You don't see, in my opinion, much really strong manual therapy being used. And both of those things have a small place. They're not the mainstay of what you'd use. In the right circumstances, it can be extremely effective.
The story I heard, and maybe it's you can add to it, was that it was a hot Adelaide day and Jeff arrived late to a practical demonstration, and the French doors were left open, and whilst the students were sitting down, a blowfly flew in, and some unknown male students caught this fly, and in the process of catching it, knocked it down, and then tried to revive it by doing little CPR movements on its back. And that was where the grade 1 mobilizations came into play. Is that a true or false story?
I wasn't there for that. There were a few years of his teaching before me. And yeah, I've heard the story and I don't know if it's true or not.
Okay, well, moving on then. So once you've done your master's or your postgrad in MINIPS, what did you then get involved with?
Well, I sort of again landed on my feet, like I said with my first physio job, because I went and worked in a private practice where Pat Trott was working. And for those who are listening and watching this, they may not know because Pat's retired for some time now, but she was one of Australia's original musculoskeletal specialists, alongside Brian Edwards, Jeff Maitland, Gwen Joel. So she was the first, one of the first. And she took over our postgrad program when Jeff retired. So being able to work in practice alongside her, being able to work with anyone who can be a mentor after you finish, whether it's undergraduate or postgraduate, is really important to consolidate your knowledge. An undergraduate is really, an entry-level therapist. They've got enormous amount to still learn. But even a postgraduate, as you know, you're not an expert when you finish. You're just better than you were. But I say you have the means to become an expert, and that is more likely to be fulfilled if you've got the right sort of attitude to keep learning, and you've got access, and that's what I had. So I had access to Pat. I then had an opportunity to work in Jeff's private practice, which was not surprisingly a great experience, because not only would he look at difficult patients with me, this was back in the day when there were curtain cubicles, so he could hear your whole subjective. And more than one time where he'd be listening to me and to say, Mark, he would add something or give me feedback, which was great, So I really kept learning a lot in those initial years after my postgrad program. Plus I moved into a bit of tutoring. I took on undergraduate tutoring, especially clinical tutoring as a clinical educator. And that also developed just a whole new interest for me in teaching.
And did that then translate chronologically into you entering into the master's program and actually teaching on it at that stage?
Yeah, so I tutored, I can't remember, a number of years in the undergraduate program and got invited to contribute in the postgrad program. And after, again, a handful of years, I can't remember, Pat retired and then asked me to take over the running of the program. So I became the program director. But I quickly add to that, I worked very closely alongside another fantastic therapist, Mary McGarry. So it was really sort of, we ran the program together largely. But yeah, so I moved from undergraduate to postgraduate teaching and really kind of fell in love with teaching.
Yeah. Now, just in looking back in some papers that I was supposed to read in 1992 for my postgrad, was it? And then I was digging out I found in 1995 you wrote a paper. It was in manual therapy titled "Clinical Reasoning and Pain," and the subheading was "The Need for Clinical Reasoning." Now, does that sort of mean at that stage that clinical reasoning wasn't being applied in clinical practice?
Definitely not. And I'm really, really adamant that at no time would I suggest physiotherapists haven't reasoned in the main. There's exceptions, and I'm sure you've come across this. So we get postgraduate students from overseas that have really poor reasoning. So there's some, because of their training, weren't really taught to reason. They were just taught to take a diagnosis and apply a protocol to that. But no, physiotherapists have always, good therapists have always reasoned. In fact, when I went back and looked at my father's work, so he was an academic days of, and a clinician in the days of polio. And so he had papers on exercise for polio. And you look back at those papers, and they were back then based on what they knew about exercise from their research, but it was all then tied to the assessment of the individual. And as soon as you're starting to tie what you do to what you assess, you're talking clinical reasoning. They didn't use that language, they didn't call it that, but they've always been doing that, applying a combination of research-based knowledge and assessment of the individual.
So this is 1995. So prior to that, you must have developed, I guess you say, a particular interest in clinical reasoning. How did that come about to the point where you actually wanted to write about it?
Well, I can't actually remember why I read this, whether it was because of my postgraduate studies or writing an essay or something, but I came across a seminal piece of research by a medical researcher called Arthur Elstein. And he wrote what is probably considered by anybody in health the landmark, what was it? It was a book, but their research, I think out of Chicago, on clinical reasoning or clinical decision making in medicine. And he talked about the hypothesis-oriented approach. And when I read their research and their conclusions, I immediately said, well, this is exactly what we do as physiotherapists. But what struck me is all of their research was focused on a medical diagnosis. So how do doctors reach a diagnosis? And of course, physios in our own way, we diagnose as well. And so that was interesting to me, and looking at, does that does that resonate with how I think we did it, how I was taught? But what also stood out to me was, wow, we do a lot more than that. We make judgments about, why has the problem. We make judgments about safety issues in assessment. We, of course, make judgments about management, which, of course, doctors do as well, and prognosis. So it started me off on thinking about our thinking and how I'd been taught. And I began to form an opinion that we can do this better. Like I was taught in Jeff's approach, I would say an analytical approach to assessment and management, but I was still following his approach. I was still doing what he taught me. And that was the same with the undergraduates that I supervised. They could be very good at what they had learned, but they were still just doing what they'd learned. And if you pinned them down, they weren't really clear on why you asked certain questions or why certain tests were necessary. So I decided that the more we could teach the reasoning behind what we do, why are we doing it? How is it helping us make these judgments? Perhaps the better our students would be in their reasoning. They're not just following what they've been taught. And I think that's proved to be true, because the more we have formally taught, not just a thinking approach, but thinking about your thinking, being critical of how you do this thing called reasoning, and have it be open. So you're not just learning Maitland or Kaltenborn or any one approach. You can then integrate anything if you've got a critical analytical approach.
Yeah. I think that's when I was going for specialization, I think that's really what struck me. You have these little watershed moments, and I'm not sure, like I used to orally, because I'm living on a farm, and so a lot of my time is actually spent doing repetitious stuff like driving around a paddock, doing something. And I remember I thought one way I can learn this and ingrain the information I'm trying to learn is actually to write it, one level of learning, speak it, second level of learning, and then third level of learning was to record what I was speaking. And then as I was driving around the track, I'd just play it back and I'd try and anticipate what was coming next in the dialogue that I had recorded about what I wanted to remember. And the clinical reasoning, it just suddenly realized that I can't just learn this by rote. My understanding needs to be to the point where I can say, I'm learning this because of this, or I'm not saying this because it's not necessary. So it was actually learning not just to give the whole lot, but just to be specific and sort of say, this is relevant, this is not. And it was that decision-making process that for me was another level above of not just regurgitate everything that could be relevant, but just picking out the key points in that particular patient's presentation that were relevant for that particular person, and also at that particular point in time, because they may have been relevant a week ago, but they're no longer relevant now. And I think for me in specialization, that was the one big thing that I learned, was trying to be quite pedantic about what was important to be included, and then why you excluded other stuff, even though you could have been included.
That's a important observation for a couple of reasons, in my opinion. One is because teachers need to know that, because teachers need to help their audience, their learners, in understanding relevance. And it doesn't always happen. So sometimes they'll stand up and teach pain science, but not connect the dots for the people they're speaking to. And the other thing that makes me think of what you were saying there was, I've got a new interest related to reasoning.
Farming?
And it's now, although I probably would like that actually, but no, it's called critical thinking. And it's not
critical.
It's been around like reasoning forever. Critical thinking. There's tons of books and institutes that teach what have you, but it's arguably analytical thinking in everyday life. And then if you apply that in clinic, it becomes clinical reasoning. But the reason I'm interested in it is if you go into critical thinking, not just what is it, but also what are the criteria for good critical thinking, it starts to make you reflect on, well, what are the criteria for good clinical reasoning? And they're largely the same. So I'll just give you a few examples. It's things like how clear, how accurate, how precise you are. It's your ability to judge relevance, and that's what made me think of it, your description there, but also significance, because something can be relevant, but not so significant. And if you think about that in our work, that's a really hard thing for students to learn.
Absolutely.
So if you try to explain to a student of all these findings, how did you choose to start there and not here? Now, on one hand, there's no absolute right or wrong. You can start, as you know, from many different angles, and you might end up in a similar place. There are some poorer choices if you're not thinking about relevance and significance. Some student starts with some exotic neurodynamic mobilization, when in reality, yes, it was positive, but it was a rather minor finding. It has relevance, but it's not so significant in this case compared to these other findings, which you've missed the significance of that. So I like the concept, and in fact, I'm now working on developing teaching for undergraduates, even first-year students, teaching critical thinking before we go into clinical reasoning.
Yeah.
And the thing I'm working on is teaching it without any reference to the clinic. So we're practicing critical thinking in life, judging, you're listening to a politician, judging person's argument and their thinking. And then what we're going to see is when you then transition that into clinical reasoning and connect the dots for them, this is what it looks like in clinical reasoning. We're just going to look and see whether that helps or not. So it's still early days, but I certainly like it. I think it's relevant.
Yeah, I love that that seesaw between significance and relevance, because I just have a new physio in our clinic, and she was asking about some neural tissue provocation tests. And I said, well, yes, they're relevant, but you've got to weigh the significance of them too, because someone might have, say, lumbar stenosis, and they may have a positive slump in the sense that it's restricted, but their body has adapted to that capacity of limited neural tissue mobility. So unless there's acute flare of it, it's not a problem. But similarly, if somebody comes in and they do have a slightly positive slump, you've got to balance the significance of that with, well, what's their active movements like? If they've got a slightly positive slump, but they've still got full range of motion, well, it's not really that relevant to their particular clinical situation. And you'd note it, but you wouldn't focus on it, and you'd move on to something that's more relevant to that person's capacity functionally. That sounds good. It sounds like you could be having some fun with that.
Yeah.
So are you involved in any sorts of, we talked about the clinical reasoning and it's sort of becoming critical reasoning. Are you involved in research at the moment, Mark, in this area or any other areas?
Well, I'm involved in a number of projects. I'm actually developing a website to teach clinical reasoning in university undergraduate, but relevant also to postgraduate physiotherapy. I've always been involved in research, but primarily as a supervisor. I've done a little bit of my own, but most of what I've done is supervised. Back in the day, graduate diplomas did little research projects, so I supervised a ton of those. Then rightly, they went by the wayside because they were just really too small to do well. But I've supervised honors and masters, and I've been on PhD panels. At the moment, I've got 2 master's students. They're all musculoskeletal research, and I'm on panels for 2 PhD students. One looking at mechanical Achilles tendon. Another one looking at, it's a baseball project, looking at mechanics in baseball throwing. So as long as it's musculoskeletal, and particularly sort of spinal and shoulders are kind of my main clinical interest. I still get involved in research, which is fun. It's really stimulating because I feel I can offer a lot from a musculoskeletal clinical application plus writing perspective. And as you know, you're involved in higher degree students, you learn along the way.
Yeah, it's definitely a two-way street, isn't it? Now, we talked about the clinical reasoning, and you've taught a lot in Australia and overseas. What is it you like about teaching?
Well, my favorite teaching is on a long program, like the postgrad programs. And that's because you get to see the students develop over time. I like PD courses, and I've really done quite a few of them, locally and overseas, and they're very satisfying. But I look at those as exposing students to new ideas, in some cases, new techniques and procedures to them, and that's really good. I still do courses, or I did up till recently, but they're never enough on their own. So when you have a long-term course, the teaching's really fun, because if you're in the classroom, either teaching theory or technique, and then you get to see these students in the clinic, you get to see them execute that, but then you get to see this thing called reasoning, application of it. And that's where it gets really fun to me. I love being able to take both a strong student, because some of these undergrad physios are amazing. They have these incredible grade point averages just to get into physio. They're just really bright kids, so they can be really good, but they have lots of gaps in their thinking and their hands often, and even the communication skills. But what's really rewarding is when you take a weaker student. And my example of that is we took a lot of international students, and we had some fantastic ones. We also had some very weak ones because of their undergraduate training being very didactic, focused, and being able to take them and make them very proficient, good clinicians, good reasoners is really fun. I mean, to me, that's more of a success than taking a good student a little bit further, taking a weak student. So I enjoyed that. And I guess part of that, I enjoyed the problem solving. Like when I was program director, and I had people, staff who we employed to be clinical supervisors, and inevitably you get the grumbles. I can't believe they don't even know this, and they can't do that, and they're complaining about some international student. Well, my first comment was, hey, that's what you're paid to do. You're paid. They're paid a lot of money, and you're being paid to do that. But I said, you need to problem solve, to work out what are their limitations. Why aren't they doing those things? Is it their knowledge? Is it their communication skills? It's probably going to be partly their reasoning. So you got to be analytical and work out their needs, and then tailor your team to already good students, and they get good results, take credit for it. So I enjoyed the problem solving of helping students.
Yeah. And flip the coin around. What's your understanding of what the students like about, or what do they particularly take away from the courses that you've been involved with?
Well, the feedback that I've had, I guess, would suggest everyone does tend to like reasoning. As long as you're not overdoing the theory part of it, people really, they don't want to just hear about it, they want to see it. So as long as you demonstrate it, or you tie it to a case, that's critical. They like that, but I think they really like the openness, because they like the fact that you're not telling them what they've been doing is crap or wrong. You're basically saying, here are some new things you can add and some things you can think about. So I think they like that sort of positive, supportive teaching, which I like to think I do.
Yeah. And where would you say the state of play is with regards to the physio profession in the world of clinical reasoning?
It's progressed a lot. So back when I studied, and I think when I did my very first paper was 1987, I spoke at a MNIPS conference in Melbourne, and I talked about reasoning. Back then, there was only probably 3 or 4 papers on clinical decision-making in physiotherapy. Jules Rothstein had sort of a classic one, and there were a couple other people that were talking about clinical decision-making. So it really wasn't out there. It was most of the literature was in medicine and nursing. Now it's just tons of literature, and theoretical literature and good research. So I've had several students do PhDs in reasoning, and it's all around. I have lots of fun corresponding with people on research projects and teaching, and it's now worldwide, and it's no longer one framework. It's Mark Jones' approach to reasoning. There's lots of different frameworks. I really think Peter O'Sullivan's framework that he's put together, which is a bit pain focused, but it's an excellent way to help students conceptualize their judgments on pain. And so it's good, you get diversity in how people are thinking about reasoning and understanding it. So that's progressed a lot.
Yeah. Was there, or has there been a period of life? Oh, sorry, let's start again. Was there a period in your physio career where you thought, this is not for me? Like you went from psychology, came to physiotherapy. Has there been a moment in your physio where you said, no, I don't really want to do this, I want to do something else?
Not for me. And I think, I don't know if that's an outlier or what, but there hasn't been. And I think that's probably because like a lot of people, I just kept adding challenges. Every practice I worked in was a new challenge for me. Teaching was a challenge for me. And, I look at what we taught from when Maitland first taught me to what we teach now. Every time we added more to our understanding of really disability, it was a new challenge of integrating that into your practice and into teaching. And as you probably know, integrating into teaching, integrating new ideas in teaching is really hard. It's not a matter of just adding a lecture to your program, because it's only going to work if you supervise it. And that means your clinical educators have to be all over it. They have to be practicing and thinking that way. Otherwise, they can't help the students. And then the students are being taught one thing in the classroom and supervised another way. So all of those challenges, I think, kept me stimulated, and I never got burned out.
Yeah, there's a lot of creativity in there, and if that's flowing fast, then it's pretty hard to get bored, if you want to say that word. But yeah, when creativity is flowing and allowed to flow, I think that keeps the interest levels up pretty high. 3 moments in your professional life that most stand out for you, Mark?
Well, yeah, so coming to Australia, doing the 1-year program was, a real turning point for me, like your Canadian experience, I suspect. And then I think I'd also say the writing, which I've been involved in around largely clinical reasoning, and our recent book, Clinical Reasoning and Musculoskeletal Practice, was sort of the, well, it was meant to be my final words on the topic. Although no sooner had that come out and I got interested in critical thinking stuff. So I do have more to say, but that was a real key thing for me, working with the clinicians that contributed to that book and getting inside their head to share their reasoning and merely kind of summarizing my thinking. That was a really key for me.
Yeah. Yeah. Almost like your PhD, so to speak. It's like an accumulation of understanding and knowledge and synthesis, and then putting it down in paper and in a way presenting it to the public, isn't it?
Yeah.
And if you could go back to your younger self, your young Ohioan farm lad wanting to be, what would be 3 bits of professional advice you'd like to pass on to yourself that you now know?
Well, I certainly didn't learn what I would call clinical reasoning. So I would like to say to myself, think more about your thinking, not just doing what you were shown to do and taught to do. I think had I had that insight back then, I would have progressed quicker. I think I would, I also, like a lot of physics, maybe back then, I focused on the physical problems. I didn't really attend anywhere near enough to the person behind the problems, what we now call psychosocial, which I think is just enormously important. And I certainly don't think that's limited to chronic pain. That's every single person we say. I feel really adamant about that. And I think that made me a much better clinician. And I think the other thing is, and again, it was of the time. Everything was about diagnosis. What is the diagnosis, the medical diagnosis or the physiodiagnosis, and what's the treatment for that kind of problem? And I don't think I wasn't thinking enough about underlying causes or predisposing factors. And so even I think in my post-grad training, I don't think we had enough on that. I think it was make the patient feel better, and we were good at that. We could send patients out feeling better, but we didn't do enough to minimize recurrence. Broadly under health promotion, but just recurrence of musculoskeletal problems, whether it's environmental things, patient problem solving, could be psychosocial related. There could be all sorts of things. I now would put more emphasis on understanding the causes. Well, put it equally alongside understanding the problem, understanding the causes of the problem, and making sure your management very quickly gets on to that and certainly leaves the patient with that ability to minimize recurrence.
Yeah. Yeah, you're really speaking to the converted there, because I think that's one thing from my PhD and then going on and doing some education in the domain of sleep. I just had no idea the hugely important significance of getting that solid 7 or 8 hours of sleep a night. And it sounds easy to say it, but I sort of, when I'm teaching and I equate it to chronic low back pain, there's no one cause for chronic low back pain. It's a multifactorial type presentation, and the peak of it is the repeated low back pain episodes a patient's getting. And I just sort of say, look, substitute repeated low back pain for repeated bad night's sleep, and you've now got chronic insomnia. And back pain is back pain, but chronic insomnia can affect your fertility, your memory, your learning, cardiovascular symptoms, your immune system, your healthy body weight. Sleep just is a complete filter over every single health problem that we see in the clinic. And pain is one of those. Like, it's predictive of pain, acute back pain. It's predictive of pain in adolescents, young adults, the whole gamut of people. It is actually predictive of musculoskeletal pain. So if we as clinicians that are truly wanting to improve a person's life over the ages of their life, or the span of their life, we need to understand sleep. It's just one of those fundamental factors that if we're not at least asking questions to find out about their sleep process and program, we really aren't getting to, as you say, the cause or the potential cause of that presentation that's in front of us at that time. And I also really like your point number two, like, I'm not sure who told me, but I said, you know, you don't think about the person's ankle, you think about the person who has the ankle sprain. And it's just flipping that round and thinking, you know, there are many ankle sprains, but each person is individual. And that's what we need to deal with as well, the person and their injury, and not label them by their injury. So I really get what you're saying there. It's again, that I didn't get that post-grad. I think it's just come on after realizing if you don't understand the person, you really can't help their injury. So the person almost has to come first.
Well, and I like your relating to sleep, because you're right, that's such a variable. And I find a lot of students will learn examples of variables depending on who's talking to them. And then if somebody's told them and convinced them that's potentially relevant, they'll add it to their assessment. But if you even go a step back and say, okay, that's one variable, but now let's just think broader about potential contributing factors and appreciate that as a construct. And then I'll share with you the ones I'm aware of and that I screen for, but I'm going to have limitations. I'll learn from someone else and they've got another variable that I haven't thought of. So don't limit yourself to my suggestions, because if you have that broader construct of contributing factors or predisposing factors, whatever you want to call them, then you'll come up with some of your own and you'll pick up more ideas. And that's what I think doesn't happen enough in teaching. Teaching is too often, it's too much, here's what you need to do. You have to have some of that, because students have to have a place to start, but you still need to give them a framework where it's coming from.
Yeah. And I think that's where it's very tough for those new grads, because we're asking them to apply clinical reasoning, but they don't have a basis from which to apply it. So it makes it's a difficult start point, and that perhaps can be overwhelming. So I think having some structure in place to say, look, here's a framework that you can work off. And as you gain experience and as you talk to other practitioners and as you treat patients, you'll be fleshing out that framework, but the framework will give you a starting point from which to get some consistency as to how you approach, you know, each and every patient that you see. So looking forward, Mark, in regards to our profession of physiotherapy in the next 5 years, where do you see it going, or what would you like to see it doing?
Oh, wow. Well, I guess one thing would be, I'd like and I am obviously musculoskeletal biased, so the critique I have comes from my observations. And I think that's worth saying, because I don't think some of the faults you see in musculoskeletal, you wouldn't see the exact same ones maybe in a good neuro or cardiorespiratory physio. I think it does vary. But I think musculoskeletal physio is sometimes guilty of swings in practice from doing one thing to now doing something different, and then doing something different. So you could say I was taught in a very joint biased approach, and then along came Paul Hodges and everybody started activating TA, and suddenly that was vogue. And then along came David Butler and Lorimer Mosley, and people started thinking about pain. And then tied to that was the psychosocial. And you could come up with other examples. These are just some of them. But I think my criticism is that people, and part of the criticism is to these people, because I think they were guilty, and they still are guilty, of selling their messages, not in an integrative way, but kind of in a damning way. So you're being damned for being too joint oriented, too hands on. So rather than saying that has a place, and here's the problem place, and here's probably how it works as we understand it. So you integrate that rather than feel guilty for still using manual therapy, or still feeling guilty for isolating a TA when other people will tell you that's long gone. You know, working out what's appropriate for the individual. And even though the things that we used and still use may not work the way we thought they were working, I may not have been elongating collagen when I was mobilizing. I may have been relaxing muscles and modulating pain. Maitland taught me to be so thorough in my reassessments. I wouldn't keep doing it if they weren't getting better. So they probably worked under different mechanisms. And so I'd like to see less of that damning of what we used to do and more integrating rather than dropping everything that came before and switching to a different way of practice.
Yeah. I'm not sure if it's relevant, but I remember talking to Brian Mulligan about this, and he just sort of said, look, I do it because it works, and I'll let somebody else work out why it works. And I thought, well, yeah, in a way, as a clinician, we can't wait to have an RCT that proves exactly what we do and why we do it, because essentially we'd be doing nothing because we don't have that sort of level of research and probably never will. So as clinicians, and it also reminded me of that manual therapy paper that you wrote, we should have written it down, but there was a point there where you said that breakthroughs come not through a body of knowledge, but come from an individual who challenges the body of knowledge. It was something like that. And I thought that really struck home to me. It was like, as a clinician, you're out there applying what you know, the knowledge that you've gained, the research that you're aware of, and the clinical experience that you have. You're applying that. And like you said with Jeff, he's turned around you and said, and hung himself out there to dry and said, I've never done this before, but based upon my reasoning and this patient, I think this is relevant. And he's going to apply that with an assessment at the start and a reassessment afterwards to confirm the outcome of that new approach that he's just created in his mind based upon all those factors that he's put together as to being relevant. And I think those things all coming together is really where we're at as a clinical profession, that we need to apply all these things that we've learned and understood, but we still need to hang out there, you know, in the wind, so to speak, and try it and use clinical reasoning to see, is this relevant or is this not? Does that make sense?
It does. And my guess is that quote came from Thomas Kuhn, who wrote this really fun book, The History of Science. And he demonstrated the major developments through time, scientific discoveries weren't, as you would anticipate, carefully controlled progressive experiments. They were often the lone inside of an individual or an accident that occurred. And yeah, that really struck me. And I think as long as, because I get it when we are critiqued for our habits of practice, just doing the same things over and over again, and our human bias. And that's a very legitimate criticism. Confirmation bias. You know, this is what I think early on, this is my first impression, and then you're set and you're focused on that. And you ignore contradictory information and you don't disprove. But that can be taught. So I do sessions with students on, here are common errors. Let's all share some. We've all made them. I'll start off and tell you some good ones I made. You know, you can put names on them. That doesn't really matter. But once you break the ice and they think, oh, well, if you shared yours, I'll share mine. Because then you get people more attuned to those, and they'll do what you say, and they'll do something extremely creative. But they still need to be critical of that. They still need to test that out, so to speak, on other patients in similar presentations, and how well does it generalize, and it does need to be researched. So we need both the research and the experience-based knowledge. But the experience-based knowledge has to also be put up to scrutiny. You know, I accept that. And if you don't accept that, then you really fall into practice. Well, clinician, I'm only going to do what works. And I don't think that's what we want to teach either.
Yeah. Great. Mark, it's been a real buzz shooting the breeze with you, and I really enjoy the clinical reasoning concepts, and it's great speaking to somebody that has evolved it, I guess, within our profession. Thanks very much for joining us on Physio+10 today.
You're very welcome. I've enjoyed it.
Thanks so much for listening to this episode of Physio+10, in which I trust you gained some valuable insights. It'd be awesome if you could leave your 2 cents worth as a review or rating of this podcast, and I look forward to sharing the story of another trailblazing physiotherapist with you in 2 weeks' time. Stay safe. Bye for now.